mute is fine.
All right, you guys are live.
Hello, everyone. Welcome to the Market Power, Consumer Behavior, and Welfare and Healthcare Markets session hosted by the American Economic Association. We have three great papers to go through with discussion. And so let's just get started. The first paper we have is titled Optimal Health Insurance in the Presence of Market Power, presented by Kate Ho.
Oh, okay.
Okay, so thank you, Robin. Let me try sharing my screens and bring up my slides.
Okay, the recording is stopped.
Okay, so I'm presenting joint work with Robin Lee, thinking about health insurance menu design. And I'm actually going to give a brief outline of two papers considering questions related to health plan menu design. The first one looks at the problem from the perspective of a large employer choosing the plans to offer to its employees. And then in a second follow-up paper, we reframe the question from the point of view of a social planner, considering optimal coverage for a single plan in that case. And in both of these papers, we're really analyzing a trade-off that's probably familiar to those of you who know this literature, the trade-off between risk coverage and moral hazard. So here's the idea. If I'm a large employer and I offer generous coverage to my employees, that's good for them because it reduces risk. It allows consumers to access the care they need. But on the other hand, if there's moral hazard in the population, consumers may respond to that generous coverage by increasing their utilization, which will increase spending, and somebody has to pay for that spending. If I'm a self-insured employer or for plans on an exchange, it's probably reasonable to assume that premiums are chosen to cover average spending. So that increased utilization means increased premiums for everyone. So there's the trade-off. Generous coverage is good because it reduces risk, but it may well lead to increased spending and hence increased premiums. So we really wanted to think about, in the context of that trade-off, what are the right coverage levels to offer to maximize some reasonable measure of welfare? For the employer, that might be average employee surplus. For the social planner, average social surplus. Today, I'm going to talk about this issue just in the context of a single plan, although of course the question also applies when multiple plans are offered. Of course, we're not the first people to think about these issues. There's a long history of economists considering questions related to insurance plan design, the choice of plan coverage for a single plan, the deductible, the co-insurance rate, the out-of-pocket maximum. And also there are many papers thinking about particular issues that arise when multiple plans are offered and enrollees can endogenously select across them. The literature with a single plan really focuses on the trade-off I've already talked about between risk coverage and moral hazard. The theoretical literature exploring that trade-off dates all the way back to Arrow 1963 and Pauli 1968. There was a small empirical literature in the 1990s using data to put numbers on that trade-off. And then there are, as I said, a bunch of papers thinking about issues that relate to problems that arise when I offer multiple plans. I'm not going to talk about those in detail because I won't be talking about that part of the paper. So what's our contribution here? Well, we're doing empirical work to try to assess optimal coverage, both with a single plan and in the paper in the context of multiple plans as well. We're using data from one large employer, which is Harvard University. Back in 2015, Harvard fairly substantially reduced the generosity of its health plan offerings, as I'll show you. The response to that from employees was fairly substantial pushback. And in response to that pushback, the university partly walked back the changes in the following year, in 2016. And we have a new data set that covers that 3-year period, 2014 through 2016. For every Harvard employee, we observe their plan choice set, their enrollment decision, and their subsequent medical claims. And we're going to use those detailed data to estimate a model of households' choices of insurance plans and their medical utilization. And the purpose of that model really is to allow us to back out or estimate parameters that describe the preferences and characteristics of the population in our data. So we're going to allow for adverse selection and moral hazard, of course, for risk aversion, and we also account for consumer inertia or switching costs when they think about switching plans. If you know this literature, the model is going to look familiar. We're really pulling together insights from models in the recent empirical literature. The structure of our model essentially follows the one in Einev et al. 2013. That's the selection on moral hazard paper. But we're also bringing in advances from Carden and Hendel 2001 and from Ben Handel's recent work as well. Once we've estimated that model, we get to the fun part, which is to use the estimates from our population to run simulations that essentially allow us to ask what might have happened if Harvard had offered a different menu of plans to its employees, with really the goal of developing a framework for insurance menu design to inform the number and the characteristics of plans that should be offered. Today, as I said, I'm going to focus on the results just for a single plan. So before we get into the details, let's think about this problem from the perspective of, first of all, of a large employer. It's not a simple problem. We really think of there being two components of the firm's problem. The first is employer spending, which comes from the premium contribution. Now, in the US, many large employers make a pretty substantial dollar contribution towards their employees' premiums. And of course, that's one component of the problem that the firm has to consider. The other component is employee welfare, and there are several inputs into that. The first is insurance coverage itself. Secondly, the underlying healthcare utilization. And we also have to think about employee costs. There's the premium, so whatever isn't covered by the firm has to be paid by the employee, and of course that's a cost we need to take account of. And there's also out-of-pocket spending. So we put all of those inputs together and generate an object that measures employee welfare. And that's really the focus of this paper. So our research question is this one: for a given level of employer spending, how to design a health plan menu to maximize average employee surplus. In our model, it's going to turn out that the optimal plan menu is invariant to the dollar level of employer spending. And that's convenient for our purposes because it means we can separate out the question we're interested in, the question about menu design, from the other important question about the right level of employer spending on premium contributions. And that's a complicated question in itself, right? Because it depends partly on local labor market conditions, what are other firms offering, and also on the extent to which employees think the premium contribution is substitutable with wages. That's all outside of the scope of our data and outside of our model. So we're going to condition on a particular level of employer spending and ask, given that level, how to design a health plan menu to maximize average employee surplus. Okay. So that's the perspective of a large employer. What about the social planner's perspective? How does the analysis change if the social planner chooses coverage instead? Well, if there are zero markups in the market, nothing changes. We can think of the social planner as maximizing average social surplus. If there are no markups, that's of course equal to average consumer surplus. And so the social planner will make the same trade-off between moral hazard and risk coverage as does the employer. So that's the case with zero markups. And by the way, that's the assumption that's made either implicitly or explicitly by most of the recent literature on contract design. But what happens, what changes if providers have positive profit margins? So you can think of that as just a different way to interpret the same spending data. So same claims data, same provider payments. We can just reinterpret them to include a positive provider profit margin. That's not going to change the employer's problem at all. In fact, it's not going to change consumers' choice of utilization either. Both of those things are a function only of provider prices. But it does change the social planner's problem because the planner accounts for provider profits. So if providers have positive profit margins, the higher is the coinsurance rate, the lower will be utilization because of moral hazard, and that brings down provider profits, right? So in the presence of positive provider profit margins, the social planner is going to choose a lower optimal coinsurance rate than would the employer. At the bottom of this slide, I've written down our sort of bottom line findings. which are consistent with that intuition. For a single plan with a zero deductible, in our population, the employer optimal coinsurance rate is 29%. From the social planner's perspective, if provider margins are zero, the planner will choose the same thing, a coinsurance rate of 29%. But if provider margins, that is the markup over price, is something like 0.3, which is consistent with some estimates in the previous literature, the social planner's choice of coinsurance goes down to 25%. If the margin is 0.4, coinsurance goes down to 23%. So that's our bottom line. Let me show you some of the details in the paper so you can see where those numbers come from. So as I said, the empirical setting comes from Harvard University, which we're thinking of as just being another large self-insured employer whose health plan offerings were historically and indeed are still extremely generous. Back in 2014, Harvard offered access to 2 insurance carriers, each of which offered 2 plans, an HMO and a point of service plan. And in 2014, they essentially offered full insurance. So they had 0 deductibles, 0 coinsurance rates, and low copays for office visits. In 2015, in response to concerns about high healthcare spending, the university introduced coverage changes for non-unionized employees. If you were unionized, your choice set was held fixed due to ongoing contracts. Of course, that's going to be useful for estimation for our purposes because it essentially gives us a control group whose coverage didn't change. But if you were not unionized, your coverage changed. The HMO and point of service plans all reduced their coverage in the same way. They all introduced $750 deductibles and 10% coinsurance rates. The response from Harvard employees, as I said before, was pretty intense resistance. In 2016, after an overwhelming faculty vote opposing the changes, the university essentially had to respond. They made only slight changes to the HMO and point of service plans, but they introduced a new option called a point of service plus option, which looked a lot like the plans that were available back in 2014. So it had a 0 deductible and no out-of-pocket payments for hospital care. So we have the data for this 3-year period, which was, as you can see, a pretty eventful period in terms of health plan offerings. And it's useful for us because we can observe how households respond to these changes in coverage, and there's enough variation for us to use that to estimate households' preferences and their characteristics. So let me show you a little bit about the data. The full sample has got around 11,000 employees, average age is 41, 48% male, 15% faculty. The second column here shows what we call the base sample, which is the sample we use for our reduced form analyses. That's not important, it's that it allows me to compare in a simple way the non-unionized to the unionized sample. So we have about 5,000 non-unionized employees, 27% of them are faculty, the rest are largely postdocs and admin staff. We've got fewer unionized, about 3,000 unionized employees. Of course, none of them are faculty. They're custodians and parking workers and restaurant workers and so on. They're a little more likely to be female than the non-unionized population, less likely to have families. They're a little younger. At the bottom of the slide, I've shown you something about spending, but it's easier to show you the distributions in a picture, so that's on the next slide. So on this slide, on the left-hand side, I have the non-unionized population. The right-hand side is unionized. Gray is for individuals and red is for families. If you know this literature, there's always a picture that looks like this, and it always looks essentially the same. So there's a mass of households with 0 spending, of course, bigger for individuals than for families. And conditional on non-zero spending, I'm showing you here the log spending distribution, and it's plausibly log normally distributed, I think. In terms of magnitudes, the unionized population tends to spend more than the non-unionized. So for example, at the bottom of the slide, I've listed average spending for 2014, conditional on non-zero spending. For the unionized population, if you're an individual, the average is about $4,300. If you're non-unionized, about $3,900. And of course, in the model, we allow for different inputs into health levels for the unionized versus the non-union population. Okay, so let me tell you a little bit about the model before I get to the simulations. It's a two-stage model of households' plan choices and their subsequent medical utilization. The full version considers multiple plans that are differentiated in terms of both financial and non-financial characteristics. Today, since I'm just talking about the single plan case, I'm going to summarize just the second stage, which relates to utilization. As I said, we're bringing together components of various previous frameworks in the literature, and we're making some assumptions that it might be useful to point out. We're going to assume that premiums equal average medical spending net of out-of-pocket payments. We assume the number of enrollees is large. That means the consumer chooses her utilization, assuming it's going to affect, of course, her out-of-pocket payments, but it's not going to have an impact on the premium she pays. And that's an assumption that's made throughout this literature. And finally, we assume that the plan is sufficiently generous that all consumers choose to enroll. Okay, so how does this model work in a little more detail? Well, households are characterized by three things. Lambda is their health needs. Omega is their household price sensitivity for medical care, that's moral hazard. And Psi is household risk aversion. In the second stage of this model, the household chooses medical spending M to maximize ex post utility. And I've written out the utility equation here. So M is the choice variable. On the next slide, I'll show you a first order condition that relates M to lambda and omega. So hold on to the first two terms for now, and I'll explain them on the next slide. In square brackets in the middle here is residual income. So Y is annual income, C of M is out-of-pocket spending, and P is the premium. And then the final term here, zeta, is a hassle cost of positive medical spending. I'll explain that on the next slide. So in stage 2 of the model, what happens? The household learns their health level, lambda, and chooses optimal positive medical spending, M star, to maximize their utility. And here's the first order condition that I talked about a moment ago. It has two terms. The first term, the silver term, gives me a way of interpreting what we mean by lambda. So lambda is going to be non-discretionary medical spending. The second term, the gold term, is the additional spending due to insurance. So for example, if I have no insurance, my out-of-pocket spending, C of M, is equal to M. C primed of M is 1, and the gold term, the second term, collapses to 0. So if I have no insurance, I spend lambda. That's the sense in which lambda is my non-discretionary medical spending. Okay, so that's the first order condition. The other thing I need to tell you about is the hassle cost. So we're going to make an assumption, which is that if the gains to the household from optimal positive spending, M star, are less than the incurred financial and hassle costs, the household is going to choose to have zero spending. This seems to us to be a natural way to rationalize the fact that we observe in the data quite a number of households who have zero spending. And we're going to estimate that hassle cost as part of the model. So I'm not going to tell you anything else about how we estimate this, except to say we estimate via simulated maximum likelihood. Let me move on and use the last couple of minutes to talk about simulations. Okay. So once we've estimated the model, we have a working framework that allows us to predict for our population what would happen if we changed the menu of plans we offered. And that allows us to think about implications for optimal plan coverage. Now, in order to talk about optimality, of course, I need to define an objective function. And in order to do that, I need to make one more assumption. So we assume constant absolute risk aversion or CARA preferences. And that gives us a functional form for the household's ex-ante certainty equivalent, which I've written out in the middle of this slide. So now I can define the employer's problem as being to maximize average consumer surplus, which we define as the cross-household average of that ex-ante certainty equivalent. And the social planner's problem is to maximize average social welfare, which is average consumer surplus plus a measure of provider profits, which I've written here as mu times M bar star, where mu is the provider's margin, assumed fixed across providers and households, and M bar star is the cross-household average of their chosen medical spending, right? So the social planner is just maximizing average social welfare. So once I have these objective functions, now I can run simulations that condition on the estimated parameters for this employee population and just trace out the change in the objective function as cost sharing changes. So let me show you that first of all for the employer and then for the social planner. So here's the employer's problem for a single plan with a zero deductible. So that's the simplest case we can think of, I think. So in this picture, on the x-axis, I have the coinsurance rate, and on the y-axis is average consumer surplus measured relative to the zero coinsurance rate point. And this really shows how the trade-off between moral hazard and risk coverage plays out in our population. So you can see that as we increase the coinsurance rate from zero, there's a loss to the individual from increased risk, but there's pretty substantial moral hazard in our population. So as we increase the coinsurance rate from zero, that reduces individual spending, pulls down premiums, and the benefit of that premium reduction dominates. So there's a pretty steep increase in consumer surplus as we move away from the zero coinsurance rate point. The optimal coinsurance rate with a zero deductible is 29%. And the average gain in consumer surplus from reaching that point is $118 per household per year, which is not enormous, but it's not nothing either. It's about 10% of the annual premium contributions for an individual in our sample. Okay, so that's the employer's problem. What about the social planner's problem? Well, in this figure, I have the same x-axis, the coinsurance rate. On the y-axis, I'm now showing average social welfare or average total surplus. And there are three lines on this figure. The top line, the red line, corresponds to the case with zero provider margins. As we've already said, in that case, the social planner faces the same problem as the employer because average social welfare equals average consumer surplus. So this red line on this figure is the same as the blue line on the previous slide. The social planner is going to choose a coinsurance rate of 29%. The other two lines on this figure correspond to assumptions of positive provider margins. So we're reinterpreting the claims data to include a provider margin with a magnitude similar to those estimated in previous literature. We're using 0.3 and 0.4. That's the green line and the purple line. So what's happening here is that as the assumed provider margin increases, the consumer surplus curve doesn't change at all because consumers respond to prices, they don't respond to profit margins, but average social welfare does change. A higher provider profit margin means a greater loss in provider profits as the coinsurance rate rises because it brings down utilization. And so a higher provider margin means a lower coinsurance rate chosen by the social planner. And at the bottom of this slide are those bottom line results that I showed you at the beginning. If the margin is 0.3, the optimal coinsurance rate is 25%. If 0.4, the optimal coinsurance is 23%. Okay, so I think I'm basically out of time. I've told you the implications of our main findings. So the employer's choice for a single plan with a zero deductible is a 29% coinsurance rate. The social planner will make the same choice if provider margins are zero, but if we reinterpret the spending data to include provider markups, then there are new additional incentives for the social planner to somewhat increase coverage in order to increase utilization and essentially to protect provider profits. I haven't had time to tell you about the other questions we consider in the full paper. For a single plan, we also look at the optimal deductible level. And in our sample for our population, we find that that optimal deductible level is zero, as we assumed in the last couple of slides. So those are the right figures to think about. We also look at the case with multiple plans. And we show that there are meaningful additional gains from offering multiple plans if it's possible to tailor financial coverage to households. But most of that is lost when households can self-select across plans. And that's a familiar result by now from Marone and Sabati 2020. We do find a way of achieving pretty substantial gains from offering multiple plans, but it requires further nuance. In particular, we find that if you can offer plans that are differentiated along non-financial dimensions, not just financial coverage, but also things like the insurance carrier and hence the provider network of the plans, those kinds of dimensions, if they differentially appeal to different household types, can be very effective in terms of allowing an employee population to capture more of the potential gains from offering multiple plans. So I think I'm out of time. I will stop there. Thanks for your attention.
Thanks, Kate. I'm going to comment on Robin and Kate's paper. Let me get some slides up here. Well, this is really a fascinating and important paper. Let me step back a little bit and talk about this. The term I'm going to use is contracting rather than plan design or menu design, because I think by using that term, it makes it clear that this falls really in a very big picture, important area that's been addressed in many, many fields of economics, public economics, labor economics, IO, particularly regulation, as well as healthcare. So there are obviously insurance contracts with consumers, which is what Kate and Robin are focusing on here, but also payment contracts with providers. And insurance contracts are relevant, of course, directly in the context Kate and Robin are talking about, but really across the board. Private insurance, public insurance, most health systems outside the US, except those that have direct provision, like the National Health Service in the UK. In every system, provider contracts are relevant. So a really big deal in healthcare. But guess what? Contracting is hard. Asymmetric information is pervasive. There are lots of other market imperfections. But we do have substantial guidance from economic theory. Probably the crowning achievement, or if not one of the crowning achievements of modern economics, is development of theory on the economics of information, which has directly led to profound work on economics of contracts. And we can bring that to bear on problems like these. Now, there is a lot of work in health economics on contracting. Most of it looks at the effects of various contract provisions, like how does cost sharing affect what consumers do, or how does the payment method affect provider behavior. There's very little work, however, that actually considers optimal or second best contracts. This is really important because we can make some progress trying to figure these things out. And Kate and Robin show us how to get some traction on this empirically, going the wrong way. Now, there are roughly 3 ways that people have gone about trying to empirically analyze optimal contracts. One way is, well, assume the contract's optimal. And that sounds a little facile, but the goal there then is to try and learn from that things like what's the distribution of unobserved characteristics? What are the factors that are driving these contracts, how they vary across entities or across times? There are 2 other approaches, neither of which assumes the observed contract is optimal, which is what Kate and Robin are doing here. They're not assuming it's optimal, they're trying to figure out what an optimal one looks like. One is to fully characterize the unrestricted optimal contract analytically and then evaluate it empirically. One can apply general theory to problems like this. Now, that sounds great, and it can be, but you need a relatively straightforward environment in order to do this. Another approach is to find optimal values of a restricted contract, like a linear one, from econometric estimates, and that's far more tractable for a complicated environment, which is the kind of environment Kate and Robin are dealing with here. It's really hard to characterize fully the optimal contract in a very complicated environment. So Robin and Kate approach number 3. As Kate told you, it's pretty darn complicated. There's a nonlinear insurance contract, there are menus of plans, there's selection, there's moral hazard, there's risk aversion. There's something in this for everybody. But they specify and estimate a rich econometric model, and they use the parameters they recover from data to find optimal coinsurance rates and plan offerings. And then secondarily, they also take account of what happens if there are markups, and particularly what the impacts are on social welfare. And not surprisingly, if you count provider profits in there and you give them positive markups, well, then you're going to alter the coinsurance rate so that you pass more money on to them. I'll talk about that in a little bit. So here are a few thoughts and questions. Overall, I think this is a terrific paper. It's an important contribution. As I think Kate mentioned, Will Manning, may rest in peace, and Susan Marquis did some foundational work on this a few decades ago, but it really hasn't been tackled in a long time. I think we need a lot more work like this. I think we can do a lot more to learn about what optimal contracts look like. We have the data, we have theory, we have the econometric machinery, and so this is a very, very welcome addition. Some thoughts on things that one might do. Some of these are things that I think are not necessarily for this particular project, but for further work, whether it's things that Kate and Robin choose to pursue themselves or others do. But thinking about effects on health, one could estimate or calibrate effects of healthcare on health. There's a really nice job market paper by Connor Ryan. So this is a little infomercial for Connor, who's on the job market this year. And it looks at some issues like this, and Connor finds that increased cost sharing, working through the mechanism of impacts on medical care demand utilization, reduces health. Jason Abelok, Bravo Hall, and Amanda Stark find people insurance plans with higher spending end up with better health. So there's some evidence out there. Now, in principle, of course, the specification here should incorporate that because people are getting utility from medical care, and presumably because they care about their health. But nonetheless, I think it's possible to account for that explicitly, and I think there are some ways that could make a difference. Of course, the optimal coinsurance rate should decline with losses, probably with prices as well. For example, it would look, I think, something like this. This is not a very pretty picture, but it's what I could gin up very quickly, right? The coinsurance rate for small losses would initially be relatively high, and then it would start declining. And what's important is also the marginal coinsurance rate would be very low, right? The change would be very low initially, but as you get to higher and higher expenses, you're getting closer to catastrophic losses, and then you want that thing to drop like a stone. It might be possible to figure out what this looks like in a simplified model, say just a coinsurance rate and premium. And what Kate and Robin have shown is that that actually would be kind of reasonable. So, of course, they didn't know that before they got started, but given their empirical results, one might consider a more simplified model and come back and consider whether one could fully characterize the optimal contract here. I want to talk a bit about the effect of market power on prices. It's worth demonstrating that markups affect the optimal coinsurance rate, but in my opinion, prices are where the action is, because what's happening in the paper right now is prices stay where they are. You just add in markups as if costs were somehow lower. But I think really what matters here are prices that are higher. And then thinking about, well, what does that do to the optimal insurance contract? So one of these things is very straightforward. Kate and Robin have this in their paper. Cost sharing can offset the effect of market power. If you have a simple insurance contract, such as a premium and a co-insurance rate, then the effective price, the out-of-pocket price to the consumer is just co-insurance rate times the price. So if price goes up, you could push the co-insurance rate down, and vice versa. And there's going to be an optimal, the second best co-insurance rate, somewhere in between 0 and 1 in that interval. And it actually that's for a fixed rate. If it was a linear contract, you can have a function that would produce coinsurance rates in that interval. Another part of this, and again, Kate and Robin are aware of this. They mention this in the paper. supply side responses. If you move around the coinsurance rate, well, then providers very well may respond to that because it affects demand elasticity. And actually, Gautam Gaurashankar and Aviv Nevo and Bob Town find there's a response, a provider supplier side response in terms of pricing to coinsurance rates. And then I'm almost out of time, but I'll throw sort of the big question that's not something that this paper is attempting to address, nor that I think it should, but I think one that we should be thinking about is why do we see the contracts we do? So in the data, the coinsurance rates and data are like 0%, 10%. There are copays of $20 and $30. These are not remotely close to the optimal cost sharing that Kate and Robin find. 29% is really different from 10%, let alone 0%. So why are employers so far away? Are they just stupid? Are people in HR departments have no idea what they're doing? I don't find that. I don't think that's right. That's not a satisfying answer. Do executives simply not care about something that's one of the biggest cost items in their budget? It's not a very satisfying answer either. Maybe this is actually optimal given what happens in labor markets and provider markets, and a very complicated thing. And Kate alluded to this as well. You can't boil the ocean. So it'd be very hard to write down a useful, coherent model that gets at all those things. Nonetheless, I don't think we have very good answers about this. And I want to make clear this is not in any way a criticism of this paper, which I think is an important contribution. But it is something for us to be thinking about going forward. Thanks very much.
So thank you, Marty. Let me take a couple of moments to respond to those great comments. First of all, the question about why employers don't do this, I think is an excellent question. I wish I had a great answer to that. My halfway answer is, well, I talked about employee pushback when Harvard tried to reduce coverage for employees. I didn't mention the faculty demonstrations in Harvard Yard and the write-ups in the national newspapers. So one response is, well, maybe they know what they need to do, it's just very hard to do it. And I fully agree with the sort of local labor market conditions story. But perhaps that's only part of the answer, I'm not sure. Secondly, I absolutely agree that the questions about markups and market power are really important. It would be very interesting to put together the model of optimal contract choice that's floating around in this literature now with a model of endogenous markups, put them together and see what we get out, and really try to address both points simultaneously, which we're not doing, explicitly not doing in these papers. So thanks, Marty. There's a terrific, helpful comments. I guess I have like 2 minutes. Let me reply to a question from Fiona Scott Morton, which I saw up here in the chat somewhere. Fiona said, why not use a PCP gatekeeper to address these problems? And I completely agree. So I presented this paper once or twice in the UK, and my discussion always essentially says, you know, what is the role of this 29% coinsurance rate? The role is to address low value utilization that's chosen by people because of moral hazard, because they barely face any price at the point of care. But of course, that's an imperfect way of addressing moral hazard, some of which may be related to choosing care for much more serious conditions than others. And a far preferable way of doing it, in my very English view, would be to have a PCP gatekeeper who could distinguish between these different cases and make the tough decisions on behalf of consumers. But that's, I think, all I have time for, and I don't see other questions in the Q&A, so I'm happy to move on to the next paper, if that makes sense to Robin.
Thank you, Kate, and thank you, Marty, again, for those wonderful comments and helpful discussion. To the audience participants, if you would like to ask questions for the remaining papers, please use the Q&A functionality, and the author will try to respond to as many as they can. So our next paper will be presented by Zach Brown.
Great. Great. Thanks for including me in this session. So this is joint work with Jihye Jeong. And today I wanted to talk about product proliferation from the viewpoint of rational inattention or endogenous information. All right, so many markets feature complicated products that require research to understand. And we now have a growing number of papers that argue that there are important frictions in these markets. So folks here are probably well aware of the literature on health insurance, but we also have a related literature on credit cards, mortgages, other complex financial products. So in all of these markets, it seems like consumers are often not choosing the lowest price. And in these markets, we often see a proliferation of products. So each firm may sell many products, some of which could be quite similar. At the same time, consumers often complain that there's too much choice in these markets. And this is particularly the case in Medicare Part D, which is our empirical setting. In surveys, about 75% of those eligible for Medicare Part D say that they favor reducing the number of plans. They say it's too hard to research all of the plans. They wish someone would show them kind of a restricted set of the good plans. And we see something similar in other insurance markets. People complain about kind of insurers offering very similar plans that are hard to compare on the ACA exchange. I kind of experienced that when I chose an ACA exchange plan. We even see, I heard a certain Nobel Prize winning economist complain that his university offered too many health insurance plans and it was difficult to choose. And so, this seems at odds with our standard models that imply welfare should be weekly increasing in the number of options in the choice set. And it's especially true in our discrete choice models with a taste shock. So in this project, we want to understand why do we see proliferation of products in these markets, and can it be beneficial to limit choice, given that consumers, at least some consumers, say they want fewer options. So in our previous work, which I'll summarize today, we estimate a demand model incorporating costly information acquisition. And we argue that endogenous information or costly information acquisition is important for rationalizing some of the behavior we see in Medicare Part D. And so this motivated follow-up work to understand the firm incentives for product proliferation in light of these information frictions. And so we're going to present a very simple model where consumers face these information costs, so they're rationally inattentive. And then we're going to show that firms have an incentive to offer similar or in some cases duplicate products. By offering these additional products, it makes it harder to conduct research to understand all of these products. Consumers are likely to accidentally choose them. This increases a firm's market power, allows them to increase prices. And then we're going to provide some initial evidence consistent with the model from Medicare Part D. So we're going to document the presence of similar plans offered by the same insurer. And this is actually something that CMS is worried about, kind of all these undifferentiated products that might confuse consumers. And then we're going to look at the relationship between these similar plans and out-of-pocket costs. So just briefly, I'll summarize the related literature. There's this related literature on information frictions in healthcare. There's also this recent work on rational inattention. Most of this work has been theoretical, so there's pretty limited work applying these methods empirically. Our discussant has some interesting work looking at the introduction of new products in an empirical setting. It's also related to the incentives for firms to obfuscate or shroud attributes. And this literature is generally not focused on the role of product proliferation. Okay, so let me start with a summary of our previous work, thinking about demand with rational inattention. So we argue that the time and effort that individuals spend understanding complex products is likely endogenous. It depends on the consequences for making uninformed choices. So, a young, healthy person might research health insurance plans less than, say, an older person who expects to need serious medical procedures that are not covered by all insurers. They're going to make sure that they understand these plans. In addition, individuals might have a different marginal cost of acquiring information, so it might be easier for some people to research these plans than others. You can think of like an elderly relative. So there's this growing theoretical literature that we're going to apply to this problem. In particular, this 2015 AER paper by Mateka and McKay. So we estimate a demand model. Utility takes a relatively straightforward form. So utility is a function of premium, out-of-pocket cost, the riskiness of the plan, and other plan characteristics. However, unlike the previous literature, we assume that part of a subset of product characteristics is initially unknown. So individuals have to learn about the details of each insurance contract to understand the out-of-pocket costs or the riskiness of each plan. And there's some marginal cost of information, lambda. The more information individuals choose to acquire, the more accurate their beliefs are going to be about these initially unobserved characteristics. So individuals are going to acquire the optimal amount of information about each option given this marginal cost. They're going to form some posterior beliefs, and then they're going to choose based on that. So I won't go through the whole derivation here, but we're able to derive analytical expressions for choice probabilities. So you can see this looks a lot like logit choice probabilities, except there's an extra parameter, lambda, which is this marginal cost of information. And actually, this is just a generalization of our standard logit model. When this marginal cost of information goes to 0, when information is free, we just get back to our standard logit choice probabilities. Okay, so why rational inattention? Well, so we estimate the model using data from Medicare Part D, and we argue that the model is important for rationalizing some facts that we see in the data. In particular, it can explain why individuals place more weight on $1 premium than $1 out-of-pocket cost, all else equal. It can also explain why individuals facing higher stakes seem to make decisions consistent with having acquired more information. So we use the model to think about a few different demand side counterfactuals. Notably, one counterfactual that we look at is what would happen if we restrict plan choice. So we hold the supply side fixed and we remove poor options or tricky options from individuals' choice set. And we show that in some cases, we can increase consumer surplus. In particular, it's optimal to remove about a quarter of the worst plans. And so this is not what a standard demand model would imply. And so this motivates our follow-up work to understand why are firms offering all of these products if they don't necessarily provide much benefit. Okay, so let's think about a simple model here. So there's two firms. They sell identical products at the same marginal cost C. Each firm may offer multiple products. So firm I sells NI products. The total number of products is N. And each firm maximizes profits, chooses price, summing over all of the products that they sell. And then consumers are rationally inattentive, so they want to choose the lowest cost option, but there's some marginal cost of information, lambda. So you can think of these firms as offering these complex contracts. Consumers research these contracts and try to figure out which is the best deal. And given these assumptions, we can derive a pretty simple expression for market share. So now we can consider the firm's profit maximization problem, solve for equilibrium prices, and markups are going to be a function of lambda, of this cost of information. So the more complex the products are, the higher lambda, the more research it takes to understand these contracts, and that's going to give firms market power, and they're going to charge higher prices. Now we can solve for firms' share as a function of the number of products they sell. And here we've plotted price. On the left, we've plotted price as a function of this marginal cost of information. So what you can see is, the solid line shows the price for a firm selling 2 products. The dashed line shows the price for a firm selling a single product. And in general, the firm selling 2 products is going to have a higher price than the firm selling 1 product, especially when the products are complicated. And then on the right, you can see that in general, as one firm increases the number of products, it's going to set a higher price and have higher profits. So what's the intuition here? So, these additional products don't have any benefit to consumers in this simple model. But when firms introduce this additional product, it takes more research to understand the products. Consumers accidentally choose them. That gives the firms more market power, and they're able to set higher prices. So essentially, these additional products are simply confusing consumers in this simple model. We can take the model one step further and consider endogenous product offerings. So we assume that there's a fixed cost of introducing each additional product, and the firm chooses prices and the number of products. And here we find that when you reduce this fixed cost of introducing products, as you would expect, the firm introduces more products, has higher prices, and higher profits. So again, the implication is that the firm offering more products is going to set higher prices in equilibrium. Okay, so to provide some initial evidence on this model, we're going to use data from Medicare Part D, prescription drug insurance. It's well known that individuals choose between a large number of plans. In some markets, as many as 40 plans in Medicare Part D. And CMS has actually been concerned with the number of undifferentiated products, and they've initiated some regulatory changes to try to get insurers to actually stop offering so many similar products. We actually spent a while looking at this. It didn't seem to have much bite. But it is something that CMS is worried about. So we start by identifying similar or duplicate plans offered by an insurer. And we do that in 2 ways. In the first way, the primary measure is to look for plans with very similar or the same plan characteristics offered by the same insurer. So this is same coverage in the gap, same generic coverage, and then a deductible, cost sharing, and quality in the same percentile. So we think that this is a pretty strict, pretty conservative measure of similar plans. And then we have an alternative measure where we define a similar plan as one that results in similar out-of-pocket cost, where out-of-pocket cost is calculated using the Ablock and Gruber calculator. Okay, so using our primary measure, we find that the average individual has 3.4 plans in our choice set that are similar or identical. In other words, you can remove about 10% of plans from the average individual's choice set without changing the variety of plans available. And again, this is a pretty conservative measure. Using our alternative measure, we actually find a higher percentage of plans that you could remove. So these duplicate plans are relatively common, or similar, very similar plans. Next, we look at the relationship between these similar plans and out-of-pocket cost. So remember, our model implies that firms that offer, insurers that offer more duplicate or similar plans have higher markups. And so we look at the relationship with out-of-pocket cost, and we find a positive correlation. So insurers that offer more similar or duplicate plans have higher out-of-pocket cost. In particular, an insurer insurers that do not offer duplicate plans have plans that result in out-of-pocket costs of about $700. Insurers that do offer these duplicate plans have average out-of-pocket costs of about $744 for the same individuals. And we don't see this positive correlation when we look at premiums, which are easy to compare. So of course, this is just a correlation. There's concern that insurers could differ in other ways. To try to get at whether this relationship is causal, we use panel variation. So we exploit the introduction or removal of duplicate plans offered by an insurer. In particular, we regress out-of-pocket cost on whether an insurer offers a similar plan, the plan characteristics, insurer fixed effects, and year fixed effects. And even using this identification strategy, we find a positive and significant coefficient on this indicator for whether the insurer offers very similar plans in a market. And so again, we think that this provides at least initial evidence that firms are introducing these products to increase markups. All right, so just to conclude, we think it's important to account for endogenous information. In this simple model, firms have an incentive to introduce additional products that don't provide any benefit to consumers in order to kind of further confuse consumers and increase market power. Then we provide some initial evidence from Medicare Part D that we view as at least broadly consistent with the model. We think this motivates future work to examine product proliferation in insurance markets, as well as other markets featuring complex products, like financial markets. All right, thank you.
Okay, let me share my screen. Yeah, can everyone see my screen?
Looks good.
Okay, thanks. Okay, so thank you very much for inviting me to discuss this interesting paper titled Product Proliferation Under Rational Inattention, Application to Health Insurance. I'm Junhui Ju at UT Dallas Navin Jindal School of Management. So here is some motivation. So let's step back a little bit and think about what has been done in the literature. Empirical papers on consumer choices under costly information acquisition have focused mostly on the demand side consequences of information acquisition cost. The common theme there has been to measure the consumer surplus loss from information friction under different contexts. To just name a few, like Hortefson-Siversen studied consumer welfare consequences of search cost in financial market. Elahonka 2014, the same thing, but in the car insurance market. Kate Ho and co-authors studied the consumer inattention cost in the health insurance market. My job market paper in 2018 studied the consumers buying quantity surcharge larger laundry detergent pack. Basically the same thing for a higher price. And to rationalize this, I developed the first tractable empirical framework in the literature that is built upon Mateka and Mekke's descriptors rational inattention. And there is a companion paper that Zach has gone over in a lengthy detail in the presentation. Now, the literature has been ripened quite a bit in this regard. But here the question comes. What are the supply side and market structure implications of the consumer's information friction? The only exception and the only existing work, as far as I know, is Grupp and Osborne 2015 AR paper that studied the bill shock regulations, which studied the supply side endogenous responses to the regulation on the bill shocks. This paper provides an interesting, novel perspective along these lines. So this paper focuses on the supply side responses and market structure implication and equilibrium, where suppliers have incentive to introduce duplicate products and raise prices, which is a novel mechanism wherein suppliers can exploit consumers' information cost. Now here's context, or a little recap on the context and empirical setup. So the context is health insurance plan choice, where annual premium is easily visible to consumers. But there can be many other costs associated with different consumer risks and plan coverages. So this is a typical example of a complicated product with many hidden prices in diverse dimensions. And obviously, learning about these plan characteristics can be very costly to consumers. So here are the author's key empirical findings. If you see this figure, this is a very cool figure. When you take a look at the horizontal axis, this is a number of similar or duplicate plans by a single insurer. And the vertical axis is the average out-of-pocket cost, basically expected out-of-pocket cost. And there is a clear positive correlation over the number of duplicate plans by insurer and average OP. And the authors provided further preliminary evidence suggesting that this can be causal. Now, to rationalize this, the authors built an equilibrium duopoly or oligopoly model of duplicated products. So the logic of the model is as follows, just to recap again. To derive consumers' demand function from choices under information friction using Mateka and Mekke's rational inattention framework. Then, assume each firm produces identical products at the same marginal cost. And then the firms maximize profit over prices, which is negative of the consumer utility in the simple model, taking the number of products that each firm is producing and the demand function from step one as given. And as a result, the optimal V's are derived, which turns out to be the same within a firm. And then, as an extension, they introduce own and competitors' fixed cost of launching more products and run the comparative statics to find the equilibrium number of duplicated products as a function of fixed cost. So here's some implications from the model. The model predicts that firms will have an incentive to launch not only more variety, but generic undifferentiated variety. Furthermore, when the firm lowers own fixed cost, then there will be higher number of equilibrium duplicated products, of course, ceteris paribus, holding everything else the same. And more duplicated products introduced by a firm will lead to higher price being charged at equilibrium, and then that's going to exploit consumer more. That'll lead to higher profit of the firm. So here's a question of mine comes. What happens if own and competitors' fixed cost both goes down to zero? Because this sounds like a more realistic situation that insurance companies will face regarding the duplicate products. As the authors note, more than 98% of insurers provide less than 3 similar plans, and I would expect that there will be much more number of similar or duplicated plans in data that is provided by a single firm. This is my question regarding the implication of the model. A little more concerning fact is the relevance of demand-side rational inattention microfoundation. So all the results from the model is derived from this first step, where they derive this logit form of demand function from rational inattention microfoundation. And all the subsequent theoretical results rely on this functional form. But step back and thinking about this and staring at this expression, in fact, the full informational random utility maximization logit, McFadden's logit, wherein the idiosyncratic utility shock epsilons are only observable to consumers but not to the firms, they yield the same implication. In fact, this has been pointed out by Anderson, Palmer thesis, the 1992 book, chapter 7, where they solve basically the identical model that is presented in this paper by the authors. So here's my question and/or suggestion is that can authors write down a simpler model with information frictions that still delivers their key predictions even absent the logic functional form? It's going to be my second question. And I'd consider there would be a little more clarification on what the identical product means. Because again, going back here, firms produce identical products, but if that includes the identicalness, includes the prices, then isn't that assuming the conclusion here? So I'm not sure about that. Maybe this is a semantic point. And another point is that do the consumers know firms' strategy that it end up leading to the identical prices within the same firm? If that's the case, then my clear think leads to something similar to diamond paradox in the equilibrium search model. So won't it be the case that if consumers know firm strategy, then wouldn't it collapse the choice within the firm to basically the same? This would be another of my question. And that's basically it. This is a super interesting paper focusing on the market structure implication of consumers' costly information acquisition. And I started myself to reflect on the big picture implications of consumers' information friction for market structure. And I'd love to see more empirical evidence, especially on the causal relationship between information cost and horizontal differentiation. Well, thank you.
Great. Thanks, Junwei. That was great. So maybe I'll spend a minute responding to a few of those points. So first, you pointed out that the demand system we use, it's basically looks a lot. It ends up looking a lot like the logit model. And actually, in our full paper, where only a subset of product characteristics are observed, it actually breaks that symmetry and it no longer looks exactly like the logit model. So that's a good point. It was just something we did to simplify things. Then your other point, what if consumers were kind of aware that firms were using this strategy? I think that's a really intriguing point. My intuition is that, you might think consumers, if consumers were aware of this, they could see a plan, an insurer offered many plans, they could infer that maybe they have higher markups, that it's less generous coverage and they don't choose it. I don't know if consumers are actually that sophisticated. So those were great points though. Maybe I should answer a few questions in the chat. So Zarek Brock Goldberg asked, does rational inattention make different predictions about proliferation as opposed to just having costly search? So I actually think costly search, you could write down a search model that has similar implications. I actually think the rational intention model here is more tractable, and I would argue that that it's easier for me to kind of think about insurance choice in the context of rational intention than search frictions, which assumes that, you know, if a product is searched, consumers fully understand it. And then our measured similar plans the same on formularies. So your point about the formulary variation is well taken. So we kind of use a proxy for that. So it's not exactly the same formulary. So the way we try to get at that is with our alternative measure, looking at the resulting out-of-pocket costs. But again, we don't think that these plans are you know, perfectly identical. Our point is that they're quite similar. And this is potentially to confuse consumers. And then Marty Gaynor asks, this sounds a lot like the old crowding product space theory in which product proliferation deters entry. And so I think that's a great point. So we have this older literature showing that firms might introduce differentiated products to deter entry. Here we're kind of showing a more extreme case where firms might even have an incentive to offer undifferentiated products that don't provide any benefit to consumers. And I think like that in that older literature, I think like the classic example that I've heard is like toothpaste. You see a ton of different toothpastes when you go to the drugstore. At least that variety of toothpaste has a benefit to consumers, arguably. Am I pretty much out of time? I don't want to go over.
Hi, Zach. You have another 8 minutes or so if you'd like to take more questions. Otherwise, we can move on to the next paper as well.
Fast. Okay, Zarek Brock Goldberg has a follow-up question. Do you need the partial obfuscation, prices, but not other features to get the proliferation result? So in our kind of previous paper, yeah, we argue that, you know, a subset of the product characteristics are hard to observe. You know, premiums are easy to observe, out-of-pocket costs are not. That's actually not necessary to get the proliferation result. So in the simple model we presented, everything is obfuscated and difficult to observe. Mark Shepard has a question. Could proliferation of Part D products be explained by other issues like trying to get more randomly assigned low-income subsidy enrollees? So Mark, did you want to, I'm not quite sure I understand. Did you want to elaborate?
Sure, Zach. So I'm thinking that, I mean, we know from Francesco De Carolis's work that insurers are strategic about trying to get the randomly assigned low-income subsidy enrollees. And they might do that by offering multiple plans that are low price and high out-of-pocket costs, because I understand there's sort of, I don't know if it's equal weighting or you just get more share if you have more plans, maybe, if you have for LIS enrollees. So I wondered if some of your results might be due to that, beyond just the rational inattention stuff that could also be contributing.
I see. So we actually hadn't thought about that, but that's good to be aware of. Yeah, it does seem like that could be another mechanism. That's actually somewhat similar idea that could be driving this. And so we should check that out. I will say we only focus on the population that is not eligible for low-income subsidies, but I see your point that the incentives for the insurers could account for those populations.
One way to check is to see, are these plans under the cap for the LIS threshold? So if you wanted to, I know there's limited things in how much you can do in this paper, but I think that might be a way to check it.
Yeah, thanks, that's helpful. Oh, Zarek Brock Goldberg says, no, LIS rule disallows this because assignment is stratified random. So that's good to know. Thanks, Zarek. Okay, I'll cede the rest of my time unless there are other questions.
All right. Well, thank you, Zach, and thank you, Junwei, as well for discussion. Let's move to the final paper, which will be presented by Mark Shepard.
Hi, Robin. Thanks very much. Let me share my screen here. And apologies that I'm a little bit side lit here, but my usual setup is I'm not usually presenting at night. I'm usually teaching during the day. So hopefully you can still see my face. Well, thank you, Robin and Kate, for the organizers, for inviting us. And I'd like to present some work today that's a little bit less based in a model than some of the work you've just seen, but is hopefully in the spirit of a AER PNP type paper, a new set of facts that are hopefully interesting to economists and policymakers about health insurance markets. So I forgot to introduce, I'm Mark Shepard at Harvard Kennedy School. This is joint work with Adriana McIntyre, who is a grad student here at Harvard, as well as Miles Wagner, another grad student here at Harvard. And our title of our work is called, Can Automatic Retention Improve Health Insurance Market Outcomes? And you may not know immediately what that means, but let me go on and as I've intrigued you with the title that you don't know what it means, to tell you what is going on. So the motivation for this paper that we've written is that covering the uninsured is a major US public policy goal. It was the big push under the Affordable Care Act to try to cover all citizen Americans in health insurance. We know that it's very important to get people in insurance in terms of improving health outcomes. There's growing evidence that it saves lives, improves financial protection for low-income individuals, and does a host of other benefits. But despite that, we've seen that it's been quite a challenge to get low-income individuals, especially, insured. And there's still about 30 million uninsured people in the United States, probably higher. That's an estimate from 2019. And among the uninsured, about 3/5 already qualify for free or subsidized insurance. And yet there's a challenge to get them to take that up. Even small barriers, as I found and others have found in past work, tend to be big deterrents for people staying enrolled in health insurance. And so given that policy challenge, the standard approach to dealing with that is to use financial incentives. So if we want more people to be insured, we make the incentive for insurance higher. So that would be subsidies for insurance, penalties on uninsurance, and that works. There's substantial evidence that that's effective, but it also has significant limits. Notably, the ACA has done a lot to make people make insurance more affordable, and yet we still have 10% of the population uninsured. So in this paper, we're thinking about an alternative policy lever that may be important, and it falls under the heading of default rules, or more broadly, the choice architecture of the market. So how you design the market in a way that you might help people, make it easier to stay insured. And we know there's substantial evidence from health insurance, as well as many other markets, that defaults matter, that what's the easiest thing to do for consumers tends to influence what happens. And so the question that we're thinking about more broadly, and we'll dive in on what we did in this paper, is whether we can use smart defaults, whether the way the defaults work within the market can be used to boost health insurance coverage. So what do we do in this paper? That's the kind of high level 30,000 foot motivation. We're going to dive in on a specific default policy that we call automatic retention. Okay, so what is the automatic retention policy? If you haven't heard that name, it's because we made it up. So I wouldn't have expected you to, but we think it's a pretty interesting policy, and one of the goals of the paper will be to teach you what it is. So this policy, automatic retention, is a policy that's intended to prevent interruptions in health insurance coverage. So these are times where you're enrolled in health insurance, and because you don't pay your premium, so many people, as will show, lapse on paying their premiums, they will get disenrolled from having health insurance. And there's an interruption where they don't have health insurance for a period of time. They need to pay their back premiums to come back. Well, the automatic retention policy that we're studying tries to set the default behavior during that time when someone lapses on paying their premiums. And it says if an individual fails to pay their premiums, again, usually a low-income individual, we should auto switch them to a free plan if one is available rather than disenroll them. So that policy tries to set the default behavior when you lapse on paying your premiums so that you're not disenrolled, but you're kept in the market in an available free plan, again, if one is available. And we'll show you a case where that is happening. We're studying this policy, which we learned about from a broader set of projects studying the Massachusetts Pre-Affordable Care Act Health Insurance Exchange. They used this policy, and I'll go into details about exactly how it worked as we go forward. It got relatively little notice. It was not publicized much. We discovered it almost by accident by digging into the data. And it's also not been followed up on in the ACA, even though there are many people for whom they're enrolled in positive premium plans and they have a free plan available that if they were to lapse on their positive premium plan, you could put them in the free plan rather than disenrolling them. So we'll show you how we study that market going forward, but just to preview what we find that the auto retention default has a major impact or a large impact on market outcomes. We find that it impacts about 14% or about 1/6 of the enrollee population per year, switching them to free coverage as opposed to disenrolling them. We find that it's actually the primary source of plan switching in the market. So it's about 3 times more common than the number of enrollees who actively choose to switch plans occur through this policy. And finally, we find that the policy differentially keeps young, healthy, and low-cost enrollees enrolled in the market, which means that it implies a better risk pool for the market and can lower the average cost of enrollees in the market, which is a key goal of these exchanges. Okay, so with that high-level summary, let me give you a little bit of background about the market and the policy we're studying. The setting is Massachusetts Health Insurance Exchange, again, prior to the Affordable Care Act. It was a market technically called ComCare or Commonwealth Care. It was introduced in 2006 under what was known as the Romney Care Health Insurance Reform. And it's in many ways very similar to what many people here may be more familiar with, the Affordable Care Act Health Insurance Exchanges, in that it provides subsidized health insurance coverage for low-income adults who are not eligible for other forms of insurance. And so when you think about the people who qualify for this market, they are not eligible for employer coverage, they're not eligible for Medicaid or Medicare. So if they're not enrolled in this market during a period that they're eligible, they're really choosing between this market and being uninsured. And we verify that empirically in the data. The plan choices are pretty simple in this market. There's a lot of standardization. So they anticipated Zach and Jihei's critiques of product proliferation and a highly standardized choice whereby all the plans actually offer equivalent coverage of medical benefits and cost sharing, and they really only differ in their health insurance networks, so which providers they cover. There's 4 to 5 participating insurers with 1 plan per health insurance carrier. The subsidies vary not in a continuous way. So again, everyone in this market is low income, they're below 3 times the poverty line, but subsidies were set in discrete income bins. And we're going to focus on 2 groups here for this study. One group is the group for whom the policy, this automatic retention policy applies, 100 to 150% of poverty. For them, the cheapest plan is always 0. That's the subsidies are set to ensure that that's the case. And more expensive plans are positive premium. We're going to compare them to a group of enrollees who are slightly higher income, the next highest group, for whom the cheapest plans are a little under $40 a month, and other plans are higher premium. Okay, so the fundamental challenge that is being addressed by this policy is the challenge that we'll call premium lapsing. So what is this? Many enrollees, they sign up for health insurance coverage, say at the beginning of the year, and they're enrolled, and they don't actively cancel coverage. So that technically they're still supposed to be enrolled throughout the year. It's not like they got a job and they didn't need health insurance coverage anymore, so they went to cancel it. It's just that suddenly they stopped paying their premiums. and the exchange will tend to send them a late notice and say, please pay your back premiums. Often they don't respond. This is a big challenge in health insurance markets. I think it's underappreciated how much this is going on. We have some data on the post-ACA Massachusetts market in which we see that this is happening among 2% of enrollees every month, or if you add that up over a full year, over 20% of enrollees are lapsing on their premium payments. So it's a very significant issue, and it's contributing to the continuing rates of uninsurance among people who qualify for very generous subsidies. So the fundamental problem here, at least in our view, is that you can sign up for coverage actively and you're in the market, but the exchange can't automatically make you pay your premiums. There's no system like via taxes to auto collect premiums. And so you've got people have to actually actively pay the premium every month. And that sounds simple, but in many cases it doesn't happen. Low income enrollees may have low balance accounts in their checking accounts and so forth. They may lapse for a number of reasons that we don't observe in the data, but for whatever reason, there's a lot of lapsing. And auto collection could be done in theory. In theory, it's been used successfully in other settings like employers, Medicare, and other countries. And tax-based solutions would be very helpful for this problem, but it's not done currently. So given the fact that there isn't an ability to auto collect premiums, when someone stops paying their premiums, what do? There's two possible default behaviors that you could think about setting up as a market designer. One is that you disenroll someone. So that's the default that's actually used in the ACA and for many groups, even in the Massachusetts market that we study. After a couple months, a grace period of not paying, disenroll them from coverage. The policy that we study takes a different approach, which is to say, okay, we've seen you not pay your bills, but you're still eligible for coverage. You haven't lost eligibility. So let's switch you by default into a free plan if it's available, and keep you in that as long as you're still eligible and as long as you don't actively opt out. Okay, so this relies on having there be a free plan available where they don't need to actively collect premiums to keep you insured. More generally, if there weren't a free plan available, you need some sort of backstop coverage where the exchange or regulators can auto collect premiums. So how did this policy work and what do we do to study it? We're going to study it for the 100 to 150% of poverty income group for whom I've already said already, their cheapest plan is $0. So they have a free plan available, but other plans in their choice set are positive premium. And they're not very high premiums. They range from $2 to $34 a month, which is less than 4% of income, even at this very low income level, but it's positive, it's a real amount. What happens instead of people lapsing, being kicked out of the market, disenrolled, they're auto switched to a free plan after the grace period. They retain the debt of the premium, but if they pay that back debt, they're allowed to switch back to their former plan if they do pay that. We're going to compare this group to a higher income group, again, slightly higher, 150 to 200% of poverty, for whom there's no free plan available. And if they lapse, they're just kicked out of the market. And we'll see that basically we don't see the auto switching happening for this higher income group. A complication of the data is that we don't directly observe a flag for this automatic switching happening in the data. Instead, what we do is we infer the use of this automatic retention policy from mid-year plan switching. So switching that happens outside of the usual open enrollment period at the beginning of the year when switching is allowed for any reason. When mid-year switching is happening, we've talked with the exchange, we worked closely with them on this project, and they've confirmed that basically, except for a few exceptions, which we dropped from our data, these reflect the auto switch policy, the automatic retention policy occurring. So we drop cases where there's a known exception where switch would be allowed in the middle of the year, and we're left with just a few unobserved exceptions for which we'll difference out the pretty low observed rate of switching in the control group and compare that to a much higher rate of switching in the treatment group, this 100 to 150% of poverty group, to infer how much of this policy is actually being used. Okay, so let me show you just some results. This paper is highly descriptive, so I'm just going to mostly show you things in graphs, and we can discuss what they mean as we go along. This is a graph that shows the rate of plan switching by month during the year. This is particularly for 2010, but I'll show you a number of years in which we study this. The months are on the x-axis, the switching rate is on the y-axis. You can see during the open, and this is the control group. Let me start with that and show you the treatment group in a second. You can see that there's a low, but still positive, about 3% switching rate for the control group during open enrollment. That's when you're allowed to switch. But during other months, there's almost zero switching among the control group. The average is about 0.2% per year. Let's compare that to the treatment group, the 100 to 150% of poverty. Here we see much higher switching in the middle of the year. So again, pretty similar switching during open enrollment. It's not like these groups are fundamentally all that different in this way, but during the year, we're seeing much higher switching. And what is that? That excess switching rate is what we're inferring as the effect of the auto retention policy. And you notice a couple things about that. First, it's higher in all months, but it's particularly high in this huge spike in month 4 of the year, in which the switching rate is 7.6% higher in the treatment group than the control group. And this is notably exactly 3 months, it's after a 3-month grace period at the start of the year. So we're gonna argue that the spike comes from the fact that plan premiums change at the start of the year when insurers rebid and reset their prices. And some plans that used to be free become non-free. Their enrollees are sometimes not even paying all that much attention. They don't pay their premium. And after this 3-month grace period, they're lapsed, and the exchange switches this huge spike of people into the free plan rather than disenroll them. So that's one feature we see of the data, the big spike in month 4, sometimes happens in month 3, but it's early in the year. We also see that there's a steady rate in all other months of about 1% of people in this year switching. So it's happening in this big spike, but it's also happening steadily through the year. And if you add up all those steady rates of switching during the year, it adds up to more actually than the spike. This pattern is not unique to 2010, which is what we showed you in the previous graph in the top left. We see basically the same pattern all years, except 2012, which I'll explain in a second. 2011, we see a spike in month 3 or 4. The grace period seems to differ between whether it's 2 or 3 months, depending on the year, but we see a little bit in 3 and 4, and then a 2% excess rate in all other months. In 2013, we see a huge spike, over 12% in month 3, and a steady rate of about 1.6% in other months. 2012, we don't see a spike, and we do see a steady rate of switching in other months. It turns out that in 2012, the plans that were free in 2011 continued to be free in 2012. And so that seems to explain, and I'll show you a little bit more evidence for this in a second, that seems to explain why there's no spike in 2012. There's not this group of people who kind of got caught by surprise. Their plan used to be free, and it became a positive premium plan during the start of the year. Just to provide a little bit more solid evidence for this story, so we argued that the spike in switching is coming from plans that shift from being free last year to not free in the current year. Again, as plan prices change and just plans, prices change as they always do in markets. This graph shows pretty strong evidence that that's where it's coming from. It breaks down the switching spike pooled across years into 3 categories of plans. One, plans that were free last year and become non-free this year. Plans that were not free either last year or this year, and then plans that are free this year. You can see very clearly in the data, there's a huge switching spike in month 4 for plans that were free last year and become not free this year. It's almost 20% of people switching out of those plans. Again, we think that's not people actively choosing to switch. That's the effect of them not knowing they need to pay premiums. They lapse on their premium after this 3-month grace period at the start of the year. And had they not been auto-switched to the free plan, they would have been disenrolled and they would not have health insurance. That's how we're interpreting this in the data. You can see that for plans that are not free last year and not free this year, there's a steady rate of auto-switching. So there's about a 3% rate of switching each month, but there's no spike in month 3. And that's consistent with a steady rate of people not being able to pay their premiums but then nothing particularly happening at the beginning of the year because there's no change in status. And then, of course, free plans in green, there's very little auto switching consistent with you can't lapse on a free plan, right? It doesn't happen. Okay, so just to summarize what we found so far, there's a big effect of the auto retention policy. When we add it all up and do a few calculations, we find about 14% of the consumer population weighted by enrollment months is auto switched per year. This is actually the primary way of switching plans. More than 3 times number of switches happen through this automatic switching policy as opposed to active switching during open enrollment. And the key channel seems to be that a lot of consumers get caught by surprise when their plan changes from free to not free at the start of the new year. What do we take away from this result? Premium lapsing is very common. It's an underappreciated problem in these low-income health insurance exchanges, and the default behavior, what the exchange chooses to do, matters quite a lot. In particular, if you set up the choice architecture in a way that makes it easy to stay insured, you'll keep much more people in the market rather than if you make the default that people are disenrolled. We do a little bit more work to understand the mechanisms for this finding. In particular, there might be 2 reasons why people are lapsing on their premiums, and then the auto retention policy is coming into play. One reason might be that the financial cost, even though it's not very much money, $2 to $34 a month, for a very low-income enrollee, that might be too much. And they might overdraft their checking account. They might just not have the money to pay. The other possible story is what we might call a hassle cost story. And that's one in which it's not so much the money, it's the fact that you have to remember to actively pay your premium. So you got to remember to write that monthly check or set up auto pay if you haven't done it already. So it's a one-time fixed administrative hassle of paying a premium. It's sort of, people haven't thought as much about this as a deterrent, but we think it's actually pretty important, especially for that spike. So we have some evidence for both mechanisms in the paper. Let me start with plans that were previously free in the prior year. And what we've done in this graph is we've broken down the switching rate in the middle of the year based on the premium of the origin plan, the plan that you were enrolled in and then you got switched out of it. On the x-axis, that's the premium of the origin plan. On the y-axis is the switching rate. What we find here, and I've broken this down based on the spike months in green and the other months in the year because of the very different patterns in those 2 periods. During the spike month, it seems to be mainly a hassle cost story. There's very little relationship between how many people are switched out or how many people were inferring lapse on their premium and the amount of the premium. And we see a very high rate even for premiums below $5 a month, in which it just is inconceivable that that's not affordable for someone. Although you might overdraft your checking account. That could be a reason why it would still matter what the amount is. For other months, though, we're seeing that the financial cost does matter. And at each $10 increase in the premium increases the mid-year switching rate by 1 percentage point per month, highly significant. So it does seem to be that both hassle costs and financial costs seem to matter here. For other plans that were not free either this year or next year, we see that the financial cost seems to matter. There's a clear relationship between the premium amount and how many people are lapsing and therefore getting auto switched. A few additional findings in the paper. First, we find that in terms of enrollment behavior after the auto switch, most consumers stick with their new plan. About 15% do pay their premium and switch back, but 85% stick with their new plan, again, consistent with people being relatively passive. We find that enrollees who are auto switched stay in the market for a meaningful length of time, an average of 10 months afterwards, and that's a significant length of time in this pretty transient market. So it's mattering for insurance coverage. It's not just a couple months of coverage, it's an average of 10. Second additional finding is that we were worried that this policy would lead to duplication of coverage. So what do I mean by that? Some people might have been thinking, maybe the reason people stop paying their premiums is because they got a job and they have other health insurance coverage, so they don't want their exchange coverage anymore. And maybe what this policy is doing is wrongfully or inappropriately keeping them enrolled in the exchange while they have some other form of, say, employer-provided coverage. Well, we were worried about that too, and I think it is in general a significant concern. We went to look at this in the all-payer claims database, which for Massachusetts, which we also have access to. And we did some work on that to try to observe duplication, a lot of details in how we did that. But the headline finding was that duplication rates were actually very low, only about 3%, and not much higher around mid-year plan switches, still under 4% for those individuals. So it didn't seem to be a significant problem in this population. That's not to say that defaults, enrollment in general, this might not be a significant concern, but we didn't find it here. Finally, additional finding heterogeneity, which enrollees were auto-retained. We find it's differentially young, healthy, and low-cost enrollees. And so I can show you that on this slide. This slide compares within this treatment group, the 100 to 150% of poverty, people who were auto-switched to all other enrollees in the second column, as well as I show you the differences for those populations in column 3. We find that the auto-switch enrollees are pretty similar in terms of income. Again, it's targeted in a narrow income group, so that's not too surprising. But the auto-switch enrollees are much younger and healthier. And that's, that makes sense. Who's going to pay less attention to their health insurance? People who are healthy, who are young, who, for whom health insurance is less consequential. So that's what we found. And in terms of medical spending, we also find that the auto switchers are lower cost than all other enrollees, and they're particularly low cost in the months after their switch occurs. So when you take that away, there's sort of two implications for the market. First, this means that auto retention will tend to improve the market risk pool. So if you think that these auto switch enrollees would counterfactually have been disenrolled from the market, by keeping them in the market, you're having a lower cost average, lower average cost population enrolled. That's an improved market risk pool. A second implication of this policy, which we haven't explored as much, but we think is pretty intriguing, this low cost, pretty healthy enrollee population who's automatically switched, they're all switched from a higher price plan to the lowest price plan in the market, the free plan, which is it's always the lowest price plan in the market. That's a benefit for those insurance plans. And they've just gotten a big demand boost among a pretty profitable group. That's interesting. That could have competitive implications. You might think that there would be stronger price competition to be that low price plan if given this policy. And we haven't explored that much, but I think it's an interesting implication of this default rule. Okay, let me just conclude. I'm close to the end of time. The key finding that we want to take you away from this paper is that defaults, in particular this automatic retention policy, can matter quite a lot in terms of reducing health insurance coverage interruptions. We find in our Massachusetts health insurance setting that this simple default rule retains about 14% of enrollees during the course of the year, differentially so among young and healthy enrollees. And the key mechanism for why this seems to matter so much is that a lot of enrollees seem not to be paying attention, and they lapse. They forget to pay their premiums when their plan was free in the prior year and becomes non-free in the start of a new year. This policy has a number of implications, which I've mentioned. First of all, it will tend to boost health insurance enrollment, leading to less on insurance, but of course, more subsidy spending for the government. That's the trade-off here. It will tend to improve the market risk pool, leading to lower average costs and premiums. And by providing greater market share for free plans, there may be competitive incentives to compete more aggressively on price. But something more stepping back, higher level, we see this paper as part of a growing pool of evidence that defaults matter quite a lot in health insurance. Auto enrollment, initial plan assignment, the default of not switching and just being default to stay with your current plan over time, those have all been shown to matter for health insurance outcomes. And so I think policymakers should be thinking more about how to use defaults and nudges in a smart way to try to lead to desired outcomes in health insurance markets. Okay, so thank you very much. And I look forward to your questions and comments. Thanks.
Thanks, Mark. I'm just going to dive in. I think that's the protocol. So this is a really nice paper. It's a great finding. I really enjoyed reading it. And the explanation was really clear, so I'm not going to redo any of the material Mark just covered. And in fact, I'm going to be very radical and not have any slides and just talk to everybody. So I want to make just really a few simple points. So one is that this is another paper in what is now becoming a relatively long line of work on the power of defaults and the need to include them explicitly when we model and estimate markets of this form. They're just a first order issue, and the traditional neoclassical model is not right for analyzing these markets. It's just incorrect. And what Mark and his co-authors show in this paper is another kind or more detail on the sort of stickiness that we have seen before. Early papers in this literature showed inertia. I have one of those, and it's really hard to know what underlies that inertia. And I think one of the really nice points about a plan that costs $0 versus a plan that costs $1 a month is that we think that some of that inertia is maybe caused just by the hassle cost of having to sign up to find a way to pay, as opposed to having it be free. So this kind of digging into individual cases and giving detailed data lets us unpack some of what's behind the behavioral, the broader pattern of behavioral stuff really matters, but it's going to be different market by market. Obviously, once you figure something like this out, it has really strong implications for the design of a private market. Let me just say that if we combine Mark's finding with Kate's paper, we, I think, learn that financial incentives and penalties are really terrible at getting consumers to do anything we'd like them to do. I mean, it'd be much better to have a gatekeeper, primary care physician, rather than a coinsurance rate to get people to consume high value care and not consume low value care in a way that therefore keeps their premiums down and also stops them from hurting themselves. And here it seems like if you just had automatic government provided insurance for the people who are poor, you wouldn't have this disenrollment problem. So that's just a side point where I think, 10 years ago, I would have told you prices solve a lot of things. And watching the literature in this area develop makes me feel like, at least in health markets, consumers don't respond very well to price signals. Okay. One of the things that I took away from the paper, and I think the evidence is quite strong in the paper, is that the choice architecture really needs to be much better upfront if we're going to solve this problem. As I understand it, the authors identify lapsing as separation after the grace period is over. Okay, they don't actually see whether somebody paid or not. So those people haven't paid their premium at all that year. And that means they signed up in December for a plan that cost $4 a month or $8 a month or something when it was previously free. So it's not a shock that arrives in May and they suddenly discover they'd rather be in a different plan and they stop paying. No, it was there it was a characteristic of the plan from the beginning, from the get-go. And so the hassle cost of paying or the elasticity, whichever it is not noticed by the employee in December or November when they're signing up. And that seems to be a major fault of the choice architecture. Like you ought to, when someone's signing up for a plan that costs $8 a month, require them to enter their bank account information in order to enroll in that plan, so that the hassle cost is absorbed right at that moment. And if the employee doesn't want to do it, then they say, gosh, maybe I should pick a plan that costs $0. That seems like a really simple thing that would make everybody better off. Now, one issue I think with the population that's 100 to 150% of the poverty level is they may not have a bank. So the unbanked population here may be discouraged from buying the plan that's $8 a month, not because they can't afford it, not because it's a hassle cost, but because they literally don't have a way to pay for it. So another policy choice I think that might be usefully built into the design of these marketplaces is some kind of community, a partnership with a bank or a financial institution or a Walmart debt card or whatever that enables people to link some kind of electronic payment scheme into the marketplace and be able to pay premiums that way. And maybe there would be banks who would be willing to partner with the government in order to help reduce the unbanked population with some kind of account that was that had no fees. I mean, if you were making a partnership of this form as the marketplace, you would want to be sure that the financial product was suitable for the clientele and was not going to end up giving them, costing them fees and so forth. So then my last point really is that there's a substantial literature now in health and in retirement savings and other financial services showing the behavioral biases of consumers and the impact on their choices. And this literature is robust and long, and we're not in any doubt about the way that these behavioral biases have impact on real markets. Less of that literature moves on to consider the impact on competition and on profits. Mark mentioned this right at the end of his talk, but I would say that that's the typical thing that I see. Maybe you get a sentence or a paragraph right at the end of your talk, and that's why Kate and I wrote the paper about what do you do if you're a plan and you face behavioral consumers and you need to optimize against that? What is the right strategy if you have this funny kind of demand, okay, generated by consumers who reliably have a behavioral bias? And so I think a good extension for this paper would be, well, for me, I think a really interesting extension for this paper would be to go in that direction. What's the impact on the optimal price? How many more customers do you get? Does it depend on whether there's a lot more plans that have a price of 0? It suggests if these hassle costs are real, that there would be a big discontinuity at a price of $1 or $2 or $3 a month. That if you're going to leave 0 and make people incur the hassle costs, you probably need to go up to 9 or something that actually lets you give a benefit to the consumer that they want so that they're willing to incur the hassle cost. That a slightly improved plan at $1 might not have much demand. And how firms optimize against behavioral consumers, I think just in general needs more research. There are relatively few papers that take that second step. And in particular, I think this literature has gone furthest in the public finance health area. And it would be really great if we could take some of the learning that we know about these consumers and move it into other markets where this concept has really been understudied. So I'm thinking in particular digital markets, digital platforms where the choice architecture is controlled by what you see on the screen. And there's very much a sense that the consumers are behavioral and the firms are optimizing against that and exploiting defaults all the time. So we enter services and there are little radio buttons that are ticked saying, yes, please email me special offers and promotions. And you have to actively unselect that radio button if you want to avoid the spam. So that kind of thing is just a huge sector of the economy where these same kinds of principles and learnings apply, but we don't seem to be doing research in that area. And in particular, I think that there's this nice flow from taking the model, figuring out what the consumers do behaviorally, figuring out the impact of competition, and then lastly, working out the optimal regulation in response to all of that. So here we're thinking about marketplace design. Should we make the people sign up their bank up front if they're going to pick a plan that's more than $0? And there's other kinds of regulations that might be yet more creative that could be thought about if we had a little bit more research on the firm optimization and therefore how you might get harm to the consumers. I think that's something that maybe we don't think is so polite to talk about, but of course the firm is maximizing profit. If it's got a demand curve, it's going to optimize with that in mind, and that might hurt the consumer. And that's something we have to really watch out for on the policy side. But overall, it's a great paper. Really love the direction and look forward to seeing more from this data set and this direction. Thanks.
Thanks very much for those very thoughtful comments, Fiona, and for the comments from the audience as well. I really appreciate a number of things you said, Fiona, particularly the last comment about what are the implications for competition. We really wanted to tackle that in this project, in this line of work, and we haven't gotten there yet, but it's coming. It's coming. So in health insurance, I can't help others attendees and panelists work on other markets because I don't know them. I do health, but others should work on behavioral defaults and behavioral issues and how regulation and competition responds, and then regulation should respond for other markets. But we are working on that in health and in health insurance, and hope to stay tuned on that. I want to say a couple responses to this and to the questions from the audience. First of all, the power of defaults issue. I think, yeah, we're totally on board with that. This seems to be a key, the key thing here. One thing that's interesting about the role of financial incentives and penalties, I think that's, Fiona commented that we sort of see growing evidence that that doesn't do good things to put the burden on consumers and health markets. I would say I agree with that for sure among low-income consumers. And that's what we're studying here, where I would extend low income all the way up to 3 or 4 times the poverty line. I'm not sure whether it might work better for higher income consumers, but we've seen, you know, growing evidence in this data and the ACA data that even very small premiums or other penalties can lead to deterring high value care, deterring people from being insured. And I think that's a really significant concern. In terms of how you set up the choice architecture in a way that you know, upfront links to a financial product so people will pay, I think that's a great line of thinking. The simplest way in our view to do that would be through the tax system. Okay, it's simplest conceptually. Administratively, getting the tax authority to work with the insurance authority can be very complicated, but one of the sort of paradoxes of the ACA is that we imposed this, we make people pay a monthly premium to be insured, and then we were going to penalize them for being uninsured, but we were going to penalize them a year later at tax time. And tax time for low-income populations is when they're flush with cash because they've gotten their refund. What if we made premiums auto-collected and being able to be collected through the tax system? It's not the easiest thing in the world to do, but I do think that that would help a lot, and that might be even easier than partnerships with banks, but maybe not. Maybe given the fact that the federal government can't do anything right, a state could actually do partnerships with banks in a way that's more productive.
What if you change the enrollment period instead of being December, you know, January to December, being something like April to March, right? And then you could get people to prepay next year's premium from their refund. And
from
it would
their
all be
refund. A brilliant idea, right? So these kind of minor things can matter quite a lot. And I love that line of thinking. Fiona, did I answer your questions before I go into the audience?
Yep, thank you.
Okay. There were a couple questions from the audience. Zarek Brat Goldberg asked, why don't insurers push harder for this policy? It seems like it makes them better off. And I think they should push harder. I'm not sure why they haven't pushed harder for it in the ACA. There are fewer zero premium plans in the ACA, but I think it could be done now that those have proliferated to a greater extent than before. There was a question that was answered about auto payment collection, whether it was possible in the market, whether you were able to sign up for auto collection via a bank. You could, but it wasn't required. And so we don't see that in our data, whether people have signed up for sort of auto pay via their bank account versus sending in monthly checks. But I would certainly bet that there's more stuff happening with people who are sending in monthly checks. Next question, there was a question from Martin Sweeney, thinking about policy questions. Are there other models thinking about customers with low dollar premiums? Yeah, I think it's worth thinking more about the policy implications here for getting ways of serving consumers with very low dollar premiums. Could the state sort of cover that and get people enrolled? I think it's worth thinking more about that. I will say that the Massachusetts Exchange has done that in the post-ACA period. They've actually supplemented the federal subsidies that are available, you know, in the normal ACA. They've added on to those as a state to make it so that there are more free plans available. And that seems to have gotten proliferated, allowed people to stay enrolled in a more robust way in Massachusetts. And we have one of the lowest uninsured rate in the country. Okay, I think I better stop there and turn it back to the organizers.
All right, and thank you, Mark. Thank you, Fiona. And so that brings our session to a close. Thanks once again to all the organizers, presenters, discussants, and attendees for a lively and engaging session.
Thanks for putting the session together. Great papers, great discussion. Thank you.